Welcome to the GPLI's Fitting Techniques and Lens Choices for Infants and Children. I am Dr. Christine Sint, Associate Professor of Clinical Ophthalmology and Director of the Contact Lens Service at the University of Iowa. There are many wonderful things in this world that won't happen unless you decide to do it. Our role as eye care practitioners is to enhance vision development in children by proactively treating pediatric eye care problems through early recognition and public education. It is important that we know all the resources available, both medically and socially, to find the best fit for the individual child. Often, this involves co-management and good communication. I like to say, it takes a village to raise an eye. There are doctors out there who are treating children with inferior methods of vision correction because they either don't have the resources or don't know the resources, think the resources are difficult to come by, or that they don't work, or they may feel too competitive and don't want to refer out of their practice. Yet, it behooves us to put our own limitations aside and look for better alternatives when it comes to developing vision in children. This resource will help guide you through the fitting process and success with pediatric contact lenses. Children wear contact lenses for both medical and cosmetic reasons. Contact lenses can enhance vision development and improve the child's self-perception. There are a variety of medical reasons for an infant or child to be fit into contact lenses, including cataracts or aphakia, Marfan syndrome, coloboma, aniridia, nystagmus, albinism, irregular astigmatism, anisometropia, and high refractive error. The most common reason for infant contact lens fitting is aphakia after cataract extraction. The incidence of infantile cataracts has been reported between 1.5 and 4.5 per 10,000 live births. There are advantages for intraocular lens implantation after cataract extraction. These include less cost to the family, elimination of application and removal, less uncorrected vision loss in patients with contact lens loss, and they eliminate the need for contact lens care. There are also disadvantages to intraocular lens implantation, which include you still have the need to patch, possible additional surgeries down the road to replace, remove, or reposition the IOL, postoperative complications, unable to predict the final prescription, the unknown effect of long-term risks, and increased stress for the parents. One study showed that surgery is much more stressful on parents than contact lens application and removal. As reported in Archives of Ophthalmology, visual acuity outcomes between contact lens treated children and IOL patients was not significantly different. However, more patients in the IOL group required additional intraocular procedures. Another common reason for pediatric contact lens fitting is ocular trauma. One study showed that over 73% of ocular trauma cases were boys, and that 7.3% of ocular trauma cases were sight-threatening. There are optical benefits to placing children in contact lenses. High-plus lenses produce ring scotomas as well as magnification and prismatic effects. Contact lenses reduce accommodative effort. However, bifocal contact lenses may be less effective than bifocal spectacles. High hyperopes have base-out prism in near gaze with their spectacles. In children with high ACA ratios, they may have reduced accommodative effort required for near tasks while wearing contact lenses. In high hyperopes, contact lenses eliminate ring scotomas, magnification, and prismatic effect associated with spectacles. In high myopes, contact lenses eliminate minification and prismatic effects. Contact lenses can be used as a patch for children who tend to be patch peekers. Some children get patch dermatitis. To help with this, apply Maalox to the skin before patch application, and put Vaseline on the patch before removal. Contact lenses are the best treatment for anisoconia. There is a 1% magnification difference per diopter of refractive disparity. Contact lenses track with the eye in nystagmus cases, and frequently reduces the velocity. Contact lenses may improve vision by 1 to 2 lines in nystagmus cases. Research has been done on cosmetic contact lens wearers. In 2010, the American Optometric Association conducted a survey of its members. 576 members responded, and 97% said they fit children under the age of 18. % of respondents prescribing contact lenses as the principal form of vision correction for children ages 10 to 12, while 49% prescribed contact lenses for the first time at 13 to 14 years old. 66% recommended contact lenses as the main form of vision correction for 15 to 17-year-olds. Of note, 21% noting that they were more likely to fit a 10 to 12-year-old in contact lenses than they were a year prior, representing an increasing trend and comfort level with fitting children. Children are able to successfully wear GP and soft contact lenses. In this study, long-term adaptation occurred more frequently to soft contact lenses than to GP lenses. The amount of time GP lens wearers are able to comfortably wear their contact lenses and the amount of itching may help determine whether they remain in that modality. Children do not require more fitting time than adults. The maximum chair time in the CLIP study was 173 minutes for children and 100 minutes for teens. Application and removal training time was 42 minutes for children and 30 minutes for teens. Therefore, any increased time in fitting children over teens was spent in the application and removal process and not in chair time. The ACHIEVE study looked at quality of life changes from wearing glasses to wearing contact lenses on a 100-point scale, 0 being bad and 100 being good. The 3 areas of greatest improvement are activities, appearance, and overall satisfaction with vision correction. However, no area got worse with contact lens wear. There are no differences in quality of life changes between children and teen, so children benefit as much from contact lens wear as teenagers. This slide represents change in each of the 6 areas of self-perception measured during the ACHIEVE study. The horizontal line represents the 95% confidence interval for changes in self-perception after 3 years of contact lens wear or spectacle wear. If the entire horizontal line is to the right of the dashed vertical line, it means that contact lenses improved self-perception in that area. If the horizontal line is entirely to the left of the dashed vertical line, and none are, it would mean that self-perception was better for spectacle wearers. If the horizontal line crosses the dashed vertical line, then it means that there isn't a significant change. There was no significant change in global self-worth or behavioral conduct. There was significant improvement with contact lenses with physical appearance, athletic competence, and social acceptance. Significant improvement with contact lenses only if they didn't like wearing glasses initially, with scholastic competence. The ACHIEVE study also looked at refractive changes, and soft contact lenses do not cause myopic creep when measured over a long period of time, even with hydrogel lenses. However, another study found subject age and lens type significantly influenced the degree of myopic progression, with younger subjects and low DK hydrogel contact lens wearers increasing more during the study. A silicone hydrogel material may contribute to less myopic progression in adult contact lens wearers. Myopia control contact lenses are developed by many companies. One type is the dual focus lens, where the central zone corrects refractive error and concentric treatment zones create 2 diopters of simultaneous myopic retinal defocus during distance and near viewing. Dual focus lenses provide normal acuity and contrast sensitivity and allow accommodation to near targets. Myopia progression and eye elongation are reduced significantly in eyes with dual focus lenses. Another area of study is orthokeratology. It is proposed that orthokeratology suppresses axial elongation in myopic children, suggesting that this treatment can slow the progression of myopia to a certain extent. Orthokeratology significantly reduced myopia in the central 20-degree visual field in myopic children. These lenses can induce myopic defocus in the periphery of myopic children and may provide potential mechanism for myopia control. Results from the CLAY study show patients' age, years of lens wear, and multi-purpose contact lens products, silicone hydrogel lenses, and extended wear are all significantly associated with corneal infiltrative events in soft contact lens wear. The use of soft contact lenses in young patients aged 8 to 15 was associated with a lower risk of infiltrative events compared to teens and adults. In summary, contact lenses benefit infants, children, and teenagers through vision performance, self-perception, and myopia control. There is no increased chair time, and new materials and wearing modalities are increasing the doctor's confidence in fitting lenses. So what's in a fit? A contact lens should provide optimal refractive correction, good mechanical fit, adequate tolerance and comfort, adequate physiological response of the eye, and adequate handling. There are some areas specific to infants that we should think about. Although corneas of aphakic eyes require less oxygen, high-plus lenses and extended sleep patterns of infants necessitate the need for high decay lenses. Additional needs specific to children include expanded powers, steeper base curves, smaller diameters, reproducible and verifiable lenses, and the ability to use medications in conjunction with lens wear. The type of lenses available to us to fit children include silicone and silicone hydrogel lenses, rigid gas permeable, both in corneal and scleral designs, and hydrogel or hemo lenses. Silicone lenses. Currently, the only silicone lens available to the market currently is the SilSoft lens by Bausch & Lomb. Advantages of the SilSoft lens include that it's fairly easy to fit and can be evaluated with fluorescein. It is a hyper-oxygen permeable material. There's a low loss rate. It's very easy to handle. And the parameters of the lens are written on the edge. Disadvantages are that it's a fairly expensive lens. Silicone is a hydrophobic material and can deposit lipids, which can often be difficult to clean. It requires frequent replacement. There's no UV protection. It does not mask irregularity and has limited power availability. The power of SilSoft lenses range from a 7.5 to an 8.3 base curve. It is in 2 diameters. The power range is from a plus 12 to a plus 32, with 3 diopter steps over plus 20. When using SilSoft lenses, the 7.5 base curve is generally fit during the first year of life. SilSoft lenses are surface treated. Over time, and frequently in a matter of weeks, the surface treatment may wear off, exposing the hydrophobic silicone below. When this happens, the lens becomes foggy and lipids deposit. The lens may look white. At this time, a new lens is necessary. When the eye is steeper than the base curve, a gap develops at the edge of the lens. This flexure of the lens can induce significant cylinder across the lens optics, reducing visual quality. Custom-made silicone hydrogel contact lenses are a growing trend. There are several labs with this capability and a wide variety of parameters available. Hydrogel lenses. Hydrogel lenses offer the advantages of comfort. They stay in place. They come in a wide variety of custom designs. They come in tints, including prosthetics and occluders, and some people may consider them relatively inexpensive compared to other types of lenses. Disadvantages is that hydrogel lenses have rather low oxygen transmission, which is important when we think about how thick an aphakic contact lens may be, which may further reduce the oxygen transmission. Hydrogel lenses require frequent replacement. They may not have UV protection, and they will stain with fluorescein during evaluation. Hydrogel lenses are difficult to verify, and some patients or parents might find them difficult to handle. They do not mask irregularity, and again, compared to some other lenses, some people might consider them expensive. Hydrogel lenses come in a wide variety of parameters, including plus 50 to minus 75, very large or very small diameters, very steep or very flat base curves, and astigmatism can be put into hydrogel lenses. Hydrogel lenses can also be tinted or painted, including hand-painted lenses, translucent designs, and stock designs. Gas-permeable contact lenses. There are many advantages to gas-permeable lenses, including low cost, quick lab turnaround, good reproducibility and verifiability. They are easy to handle, they have excellent optics, and can even mask astigmatism on the corneal surface. They can be UV protected, and they come in a very high oxygen transmission. The disadvantages of gas-permeable lenses include prolonged adaptation in older children, although infants don't seem to mind, greater skill necessary to fit the lenses, lens loss or dislocation, and potential corneal abrasion. Gas-permeable lenses are also available in a large variety of parameters. The doctor has control of all the parameters on a gas-permeable lens. The fit. While the vast majority of contact lenses can be done in the office, occasionally a child may need to be sedated to achieve a proper contact lens fit. Your exam under anesthesia kit should include a retinoscope, trial lenses or skioscopy bars, a handheld keratometer, contact lens trial sets, lens solution or saline, sodium fluorescein, handheld slit lamp, exam forms, and don't forget your pen. A very bright cobalt light is necessary for accurately evaluating fluorescein patterns. My preference is to either hold the child up to the slit lamp or use a cobalt LED light. Burton lamps generally do not provide enough illumination. Children can be held up to the slit lamp as young as 4 months of age. Pediatric lenses are fit relatively large. Select a lens approximately 1 millimeter smaller than the horizontal white-to-white diameter. In a retrospective analysis of 323 aphakic children fit at the University of Iowa from 2000 to 2010, the average contact lenses diameters were 9.0 up to 6 months of age, 9.3 from 6 to 12 months of age, and 9.8 at greater than 12 months of age. The base curve may be selected by either obtaining parametric readings or guessing. I find selecting the average base curve and then adjusting according to the fluorescein pattern to be easier than obtaining keratometry readings in small children. The contact lens really is the best topographer. The average base curves are 46 up to 6 months of age, 45 from 6 to 12 months of age, and 43 at 18 months of age and older. You'll want to fit on K or slightly flatter than the average K. Just like you would with adults, adjust the fit according to the fluorescein pattern. Occasionally, some children will have significant corneal astigmatism. I suggest fitting spherical lenses if there is not significant liftoff and lid catching. Until the child is older and accurate K measurements can be obtained, a GP lens will mask the corneal cylinder, creating a nice optical image. Good retinoscopy skills are essential for working with children. Off-axis retinoscopy will result in aberrations. Remember to vertex the retinoscopy findings and add it to the lens power. When I hold loose lenses, I place my finger in the lateral canthus and use my finger depth as the vertex distance. Don't forget the near add in the overall power of the contact lens. Generally, it's going to be +3 until age 2, +1 to 1.5 at ages 2 to 3. Over that age, you generally want to have the child focused at distance and use bifocal glasses. Let's give an example of lens power calculation. If the spectacle Rx is +25, the vertex corrected contact lens power will be approximately +36. Put an add on that of +3, and the final contact lens power is going to be +39. Children always perform best in a routine, so establish a daily ritual. By removing the lens every day, the caregiver will become proficient and the child will be more cooperative. A clean lens is a comfortable lens and will have decreased complications. Babies can learn to use sign language as early as 6 months old. I encourage parents to come up with their own signs to communicate about the contact lens. Around 9 months old, children will put everything in their mouths, including the contact lens if it pops out. Reassure the parent that eating the lens won't hurt either the child or the GP lens. If the parent happens to find it in the diaper, it can be cleaned and disinfected with a 4-hour soak in peroxide. Infants are easy to hold and can be held either in the arms or simply swaddled in a blanket. As children get older and stronger, you may need to do other holds, including the 2-person hold. two-person holds involve having one person stabilize the head while the other person stabilizes the body from rolling or kicking. Frequently, however, only one person is available. One-person holds involve sitting on the child, which is actually just hovering over the child, with your knees and legs securing the head and arms. This will keep the head still and the arms held down. Don't worry about the legs kicking. Advise the parents to be persistent in the application. By being persistent, eventually the child will not have to be held at all. During insertion, it is easy to drop the contact lens, so fresh solution should be available to rinse the lens. It is important to control the child's arms so he won't rub the lens out after insertion. The lids can become very slippery and swollen from crying and lid manipulation. Wet eyelids make it very difficult to insert the lens. Always keep a tissue handy to dry the lids between attempts. If you, the parent, or the child becomes too stressed in the process, take a break, breathe deep, and reassure the parent about why they are doing this and their eventual success. To insert the soft lens, hold the lens as a fan shape between your thumb and your first finger. Do not pinch too tight or you may crack the lens. Hold the upper lid with your thumb, securing the eyelashes to the brow bone, creating a gap under the upper lid. Pull down on the lower lid with the middle finger of the opposite hand. Place the lens on the eye under the upper lid. Let go of the lower lid first and then the upper lid. The upper lid is really tight. If you let go too soon, the lens will flip back out. The lower lid pushes the lens up under the upper lid. Soft lenses can be removed two ways. The lens can be pinched or wiped out, just like in adults. The other method is to pop the lens out with the lid margins. Hold upper and lower lid margins. Pull the lids apart and press onto the globe to pop the lens out. Using your thumb, secure the eyelashes to the brow bone, creating a gap under the upper lid. Either hold the lens between your fingers of the opposite hand or rest the lens on the lower lid margin. Gently slide the lens up under the upper lid. Then, gently pull the lower lid down with your middle finger while still securing the lens. To remove the lens, place the thumbs at the lid margin. Placing the thumbs adjacent to the actual lid margin will cause lid flipping. Separate the lids so that they are on either side of the lens, pushing into the globe, and then push the lid margins under the lens. Make sure the lens is in the eye before removal. Visualize the lens edges before pushing into the globe. Lenses will occasionally go missing. Assure the caregiver that the lens will not fall back behind the eye or into the brain.
Now, Anita, do you want to show how to push it back? Or do you want to push it back?
Look, Mom did.
Okay. Perfect.
To recenter a dislocated lens, locate the lens in the eye, and then, either through the lid or with the lid margin, push the lens back into place. If it is stuck, squirt saline up under the upper lid to wet and loosen the lens. Then check to make sure the lens is in place. If all else fails, use a suction cup, being careful not to plunge the eye. Reassure the parent that what goes up must come down, and the child is not at risk if the lens has to stay in the eye. By manipulating the lids too much, they will become swollen and more difficult to move the lens. It is better to take a break and come back later. For best comfort and to prevent the lens from popping out, it is best to lubricate throughout the day. Drops can be placed either with the eyes open or in the corner of the eye if the eye is shut. The drop will roll into the eye when the child blinks. As a reminder to parents, drops should be placed in the eye with every diaper change. Drops should also be placed after naps. The wearing time is ramped up relatively fast compared to adults. Infants seem to adapt faster to GP lenses than older children or adults. Parents are always interested when the child will take over the responsibilities of contact lens care. Children are generally capable of removing their own contact lenses before the start of preschool or kindergarten, at age 4 or 5. They are generally able to insert the lens around age 6 to 8 and take over all responsibilities of lens care from 10 to 12. At progress evaluations, a lens history should be taken, an attempt to document visual function, including the parent's impression. The child should have a refraction or retinoscopy performed. The lens fit should be evaluated, and then the physiological tolerance of the eye to the lens as well. The lens should always be removed and inspected. Parents should be instructed to contact your office immediately if they suspect redness, secretions, visual blurring, or pain. Troubleshooting. If the parents report that the lens is repeatedly popping out during the day, the lens could be too steep, the child could have significant esotropia, you could have increased intraocular pressure, the center or edge of the lens may be too thick, or there may be excessive toricity with edge lift. If the lens is sliding off the eye but not popping out, rather dislodging itself in the corner or up underneath the lid, that is highly suspicious that the lens is too flat. Steep-fitting lenses pop out, and flat-fitting lenses slide off the cornea in infants and small children. In this case, this little boy is a premature infant who was born at 25 weeks gestation. He has ROP in both eyes, with high myopia in the right eye and is aphakic in the left eye. After 1 year of lens wear, his contact lens in his left eye started to pop out. As you can see, this child grew, and the lens became significantly steep. This little girl is aphakic in both eyes and has significant esotropia. The parents reported that the lens would stay in when the other eye was patched, but would pop out when she used both eyes together. The patient was referred for strabismus surgery, and after that, the lens stayed in. The parents of this young man with aphakia in the right eye reported that the lenses started popping out. The eye was not turning, and the fluorescein alignment and the size looked good. However, his intraocular pressure was elevated, causing the lens to pop out. In this 8-month-old female, her old lens fit well and stayed in, while the new lens, which was the same parameters, was popping out. When the lenses were inspected, it had a very blunt edge. In general, the lenses may pop out if the center thickness is greater than 0.7 millimeters, or the edge thickness is greater than 0.2 millimeters. A patient may show signs of loss of fixation if there is dense amblyopia, the contact lenses are in the wrong eyes, they're wearing old contact lenses, or there is acute pathology. This young man is a 1-year-old aphakic who stopped fixating when patched. The referring surgeon said I overplussed him by 9 diopters. What happened? The retina was 9 diopter closer to the front of the eye, and he was treated for his retinal detachment.